So every panelist, I'll request you to have 4 minutes to give your views about how to strengthen the harm reduction services for key populations going forward. We saw a presentation from Malaysia, we saw presentations from Pakistan, and how to take this forward and how to strengthen it in future. So first of all, I would request Professor Adiba to please give your feedback.
Thank you very much, and assalamu alaikum once again. I guess listening to the presentations from colleagues here from Pakistan, there are many different aspects that we need to think about, but given that OST is still relatively new in this country, am I correct?
It's not yet launched.
Not even here yet?
No.
Perhaps that is one area that I would suggest that you really focus on, because as you can see, having both the needle syringe program, the OSD, in Malaysia almost simultaneously has helped us a lot. This will require, at what stage of approval is it at?
Well, the government has approved for buprenorphine to be used, not methadone. But we have not yet started services. The first OAMT center is being established in Karachi. Sindh always takes the lead in all the new interventions. So the building is almost finalized. They're in process of hiring the staff. And the last part of the puzzle is procurement of the drugs, which is underway. There we have a lot of problem because of the regulatory bodies, because it is a controlled drug and we cannot import it from outside the country. And we have been asked to procure it locally. Now locally there are 2-3 pharmaceutical companies who have got the registration to, permission to start manufacturing, but they haven't started manufacturing yet. They're waiting for the orders.
I see. And the reason for not using methadone is?
It's with the Ministry of Health and the Ministry of Narcotics Affairs, Narcotics Control, that they have been in discussion for a very long time. And in principle, they have agreed on methadone also. And now the discussions is around the pricing and the dosage. Yeah, regulatory approvals.
Yeah. Okay, that's good. Because, well, we actually in Malaysia, and Anita, you can chime in as well, went for methadone simply because it's so much cheaper. When we first started using methadone, it was relatively expensive compared to the rest of the world, but now it's super inexpensive. And judging by the size of the problem that you have here, I would imagine that would be a more cost-effective approach. I know buprenorphine is available in generic form, but it's still more costly than methadone. The second thing is the reason why when we started harm reduction in Malaysia, we went with methadone rather than buprenorphine, because when Reckitt first brought buprenorphine into the country, it was completely without any regulation and it was abused. There was a lot of cases of injecting of buprenorphine because the price was high and people who use drugs were cutting up the buprenorphine and injecting it, so it actually defeated the purpose. And so that's why the government actually went for methadone. I know that there is, in certain quarters, that methadone gets a bad rap, but with proper training, proper SOPs in place, as we have shown, it can be scaled up relatively quickly.
Okay. Thank you very much. Now I would request Dr. Saima for her views on recommendations for strengthening the harm reduction services.
Thank you. I wouldn't want to repeat a lot of what we've already mentioned, but some of the key pillars that we can focus on, knowing how the epidemic in the country is going, that we have 8 specific activities for our youth for adolescents that they're at a stage of life where they tend to mix with thrill, pleasure, with their academics, with their work. Child labor is an issue in our country where people are engaged in work. Looking at the current economic situation, they're there. So when our harm reduction services are there, I think on a policy level, at a broader picture, we need to take it up, engage different social media, the electronic media, the print media, to create awareness about an issue that is there, and then to teach youth how to navigate through peer pressure, through company, to engage in a behavior that they are comfortable with. So this would require some structural engagement where we can have different departments from the government, the education department, the culture department, the information departments that come in. Secondly, for strengthening harm reduction programming, we need to have community-specific, community-led programming. Communities who understand the dynamics of their respective community members, they'd be in a better position to deliver services. Their beneficiaries would be in a better position to understand what they're saying. And like the earlier speaker mentioned, the regulatory processes, continuous engagement with our higher-ups to make this acceptable, to sensitize them, and to actually take OMT forward from the supervised setup to maybe a community setup that is mutually acceptable to all.
Thank you very much, Dr. Saima. I would now request Dr. Sikandar for his views. Just to give you a background that why I said that Dr. Sikandar is an inspiration and Sindh always takes the lead. Whether it's a PrEP, whether it's differentiated service delivery, whether it's OMT, they're always open to new ideas, to new interventions, and they discuss with the technical partners, with the beneficiaries, and then they just go for it. So thank you, sir, please.
Thank you very much for your compliments. Thank you very much for all. I would suggest I would add few suggestions because the experts have already expressed many views. As far as Sindh is concerned, there are 14 COP sites. They are definitely working well and covering 24 districts out of 30. But I would suggest this expansion should be up to 30 districts so that everybody who is injecting drug users be benefited from these services because they are doing very well. Number two, as far as injection syringe and needle services are concerned and condoms. Number two, OMT services being started at Sindh province and JPMC. Karachi is a largest city of the country, and I don't think people who are injecting drugs in the graveyards, in the railways, and the different spots which are 40 kilometers away from the JPMC. There should be a small city from where we should be pilot this project, but because we have already decided, so we have to change the model by putting social mobilizers in this because somebody should be there to bring all drug addicts on the centers and take away them at their spots. Otherwise, a drug addict will never bother to come on the center by spending his own money on fare of the vehicles and come on the JPMC center and take away one pill for one day and he has to come tomorrow again. Unless it is proved that it is very good drug and it is very beneficial for them, then they self-come. Otherwise, the model should be changed that social mobilizers with vehicles, they go into the field and bring the clients. This is my suggestion. And otherwise, harm reduction is also implemented by the other CBOs by distribution of condoms and counselings, many other things. We are also taking part as a treatment partners because they are testing the people at the sites and bring them on our treatment centers. We get them registered and provide them treatment we counsel them for adherence. Adherence is equally important for their reduction of infection and spread of infection. Thank you very much.
Thank you very much. In the end, I would request Mr. Rana Javed. Rana साहब, आपने बेसिकली ये बताना है कि फ्यूचर में आगे जाते हुए हम हार्म रिडक्शन सर्विसेज को किस तरह मजीद मजबूत कर सकते हैं, किस तरह मजीद बेहतर बना सकते हैं.
मेरा अपना ज़ाती ये ख्याल है, मैं खुद भी एक्स-ड्रग यूज़र हूँ, तो जब तक इनकी सर्विसेज वहाँ रीच करके नहीं पहुँचाई जाएंगी तो उससे फ़ायदा नहीं होगा. जिस जगह पे ये नशा कर रहे हैं आपको वहीं जाना पड़ेगा, उन्हीं थालों में उतरना पड़ेगा, उन्हीं जगहों पे जाना पड़ेगा, क्योंकि इसलिए कि वो लोग तो मैंने तो वो ज़िंदगी भी गुजारी हुई.
अब वलीद साहब को थोड़ा ट्रांसलेट करना.
जी जी, he is saying that being an ex-drug user, I would suggest that it should be given at the spots that OMT, he's talking regarding that OMT, that it should be provided at the spots, as a drug user cannot travel to the hospital or far away from that spot.
बगैर तसब के, बगैर किसी नफरत के, हकारत के उसको वो सर्विसेज देंगे तो वो प्रोग्राम कामयाबी से चलेगा.
Without any
थोड़ा सा भी
differences.
जी,
मैं साथ साथ कह रहा था, without any differences, if that program is allowed, so it will be a beneficial one.
ताकि ये तासब की जो फ़िज़ा है वो ख़त्म हो और बहुत सारे लोग इससे फ़ायदा उठा सकें. जो भी प्रोग्राम है उसमें सबसे पहले जैसे होता है ना एक कदम आगे बढ़ना, तो एक कदम आगे बढ़ेंगे तो खुद ब खुद हर चीज़ मेंटेन होती जाएगी. वो आते जाएंगे सर्वर टू चैन के ज़रिए आते जाएंगे. ये खुद अपना पैगाम एक दूसरे को देना शुरू कर देते हैं, मगर इनको प्यार और इज़्ज़त की ज़रूरत है.
Respect and dignity matters a lot for that IDUs, and they will spread that message. If one person get that OMT, so they will spread that message, and that will cover a large population of IDUs.
मुआशरा इन्हें कबूल करे, ये बहुत ही इज़्ज़त करने वाले लोग हैं. थोड़ी सी रिस्पेक्ट इन्हें दे के देखें. ये बहुत स्किल्स होल्डर लोग होते हैं, आप इनसे एक मरतबा ट्रस्ट तो करके देखें.
They should be respected and trusted. They can be trusted.
कुछ और कहना चाहेंगे?
हाँ,
कुछ और कहना चाहेंगे आप?
मैं ये थोड़ा सा बताना चाह रहा था.
जी जी जी.
अस्सलाम वालेकुम जी, मेरा नाम राना जावेद है और मैं इंटरनेशनल एड सोसाइटी और तमाम ऑर्गेनाइज़र्स को नहायत मशकूर हूँ जिन्होंने इस सिम्पोजियम में का इनेकाद करके मुझे ड्रग यूज़र कम्युनिटी और हार्म रिडक्शन पर इज़हार ख्याल का मौका दिया.
Ira Najaved would like to express my gratitude to IS and all the organizers who provided me with the opportunity to share my thoughts on harm reduction strategies for the drug user community by inaugurating the symposium.
जब मैंने नशा शुरू किया उसके कुछ ही अरसे बाद जहनी व जिस्मानी नुकसानात के साथ साथ माशरती व जिस्मानी नुकसानात का भी सामना करना पड़ा. ताहम नई ज़िंदगी ट्रस्ट के तवस्सुत से दीगर नुकसानात के साथ साथ ज़िंदगी की अहमियत को जांचने और पहचानने का मौका मिला.
I started using drugs, and after some time I had to face not only mental and physical harm but also social and financial problems. Thanks to Nayi Zindagi, I got the opportunity to understand and recognize the harm caused by drugs not only to myself but to my loved ones.
नशा करने के दौरान जब मुआशरती और समाजी सतह पर तासब के बोझ तले ज़िंदगी गुजार रहा था, उस वक्त मैं नई ज़िंदगी की बदौलत दी जाने वाली मालूमात और सहूलियात के ज़रिए ये जानने का मौका मिला कि नशा करने से ना सिर्फ अपना नुकसान है बल्कि मेरे साथ जुड़े मेरे दोस्त अहबाब, अजीज़ रिश्तेदार, बीवी बच्चे सभी किसी न किसी तरह मेरी वजह से मुतासर हो रहे हैं और मज़ीद भी हो सकते हैं.
During my drug use, I was unaware of the social and financial burdens I was putting on my family, but through the trust, support and resources, I realized that my addiction was not only harming me, but also affecting my friends, relatives, wife and children in some way or another, and may still have an impact on them in the future.
जैसा कि पहले प्रेजेंटेशन में आपको बताया गया है कि नई ज़िंदगी किस तरह से हार्म रिडक्शन पर काम कर रही है, लेकिन मैं यहाँ OAMT के बारे में बात करना चाहूँगा. जैसा कि सुनने में आया है कि ये दूसरे ममालिक में कामयाब तरीक़ाकार से देखा गया है और नशा के स्टिग्मा को कम करने के बारे में बात करना चाहता हूँ. नशा के स्टिग्मा को कम करने के हवाले से भी मददगार है। हमारे मुल्क में बहुत से लोग नशा करते हैं, दोबारा नशा पर लग जाने के बाद इनके पास कोई ऑप्शन नहीं होता।
As mentioned in previous presentations, Nayi Zindagi has been working on harm reduction. However, I want to talk about OMT here. As I have heard, it has been a successful approach in other countries and also helps reduce the stigma associated with drug addiction. In our country, many people struggle with addiction and after relapsing, they often have no other options left.
ताहम बतौर एक्स ड्रग यूज़र मुझे लगता है कि अब भी सारे इकदाम और इस काम और इकदामात को मज़ीद बेहतर किया जा सकता है। ख़ुसूसन मैंने OAMT का जिक्र किया है। अगर इस तरीक़ाकार को भी बाकायदा तौर पर सरकारी या निजी सतह पर मुतारफ़ करवाया जाए, जैसा कि सुनने में आ रहा है हर सूबे में इस तरह के सेटअप को मुतारफ़ करवाया जाएगा, तो इसके नतीजे में मेरे जैसे बहुत से भाइयों की ज़िंदगी को बेहतर किया जा सकता है।
However, as an ex-drugs user, I feel that there is still room for improvement in these efforts. Specifically, I mentioned OMT, which if introduced formally at the government or private level could lead to better outcomes. As I have heard, setting up such facilities in every province can result in improving the lives of many brothers like me who struggle with addiction.
WHO और UNODC ने भी OAMT को भी नशा करने वालों के लिए मौसर बताया गया है और ईरान, अफ़गानिस्तान और इंडिया में इस तरीक़ाकार को शुरू भी कर दिया गया है और ये तरीक़ाकार बहुत कामयाब रहा है। अगर इसे हमारे मुल्क में भी इसको जल्द अज जल्द शुरू किया जाए तो ना सिर्फ नशा के स्टिग्मा को कम किया जा सकता है, बल्कि नशा करने वालों की जिस्मानी और ज़हनी सेहत को भी मज़ीद बेहतर किया जा सकता है।
The World Health Organization and UNODC have also recognized OAMT as an effective treatment for opioid addiction, and it has been successfully implemented in countries like Iran, Afghanistan, and India. If we can introduce this treatment in our country as soon as possible, we can not only reduce the stigma associated with drug addiction, but also improve the physical and mental health of drug users.
मिसाल के तौर पर मंदरजा झैल मामलात को संभालने में OAMT का तरीकाकार सुधकार हो सकता है।
For instance, OAMT can be beneficial in addressing the following issues.
ओवरडोज होने की वजह से बहुत से लोग अपनी जान से हाथ धो बैठते हैं। इसकी मदद से बहुत सारे लोगों को इस मसले से बचाया जा सकता है।
Many people lose their lives due to overdose. With OAMT, many lives can be saved from this issue.
जिस्मानी तकलीफ और नशा के बगैर ना रहने के डर से बहुत से लोग नशा की आदत को नहीं छोड़ पाते, मगर जैसा कि सुनने में आया है OAMT की मदद से जिस्मानी तकलीफ और क्रेविंग और रिलैप्स की शरह में कमी देखी गई है।
Many individuals struggle to quit drug use due to physical withdrawal symptoms and the fear of relapse. However, as I have heard, OAMT has been successful in reducing physical withdrawal symptoms, craving, and relapse rates.
बहुत से ममालिक में HIV की शरह को कंट्रोल करने के लिए OAMT की मदद ली जा रही है और ऐसे ममालिक में HIV की कमी की शरह देखी गई है, क्योंकि लोग इंजेक्टिंग छोड़ देते हैं और बीमारियों और पेचीदगियों से बच जाते हैं और खून से फैलने वाली बीमारियों HIV और हेपेटाइटिस की शरह में कमी हो सकती है।
In many countries, OAMT is being used to control HIV rates, and a decline in HIV cases has been observed in such countries. This is because people discontinue injecting drugs, avoid diseases and complications, and the transmission of blood-borne disease like HIV and hepatitis C can be reduced.
आखिर में नशा करने वाले लोगों की नुमाइंदगी करते हुए मेरी अपील है, कौमी सतह पर OAMT को मुतारफ़ करवाया जाए। OAMT की सर्विसेज की हसूली इतनी ही आसान बनाई जाए जितनी हार्म रिडक्शन सर्विसेज की हैं। इस सहूलत से इनफरादी और कौमी सतह पर फ़ायदा उठाने के लिए ज़रूरी है कि एक नशा करने वाले के लिए इसकी रसाई इस तरह होनी चाहिए जैसे हार्म रिडक्शन की सर्विसेज हैं, यानी नशा करने वालों के लिए इस सर्विस को मुकम्मल तौर पर इनके करीब किया जा सकता है, करीब होना चाहिए। शुक्रिया जी।
Finally, representing drug users, I appeal that OAMT be introduced at the national level. OAMT services should be made as easily accessible as harm reduction services. It is essential to make this facility available to individuals and at the national level to benefit from it, just like harm reduction services. In other words, these services should be completely accessible to drug users just like harm reduction services and should be easily available to them. Thank you.
Thank you very much. Now we will have a question answer session, and first of all I will ask the question because this question was in my mind for a very long time, so I now got the chance. So we have been talking, when we talk about harm reduction, we have been talking mainly about opioids and needle syringe exchange program and OAMT. But in the last few years, we have some new drugs in the market, and which are totally, changing the landscape, especially the youth, because we are working with the three key populations of MSM, TG, and FSW. So we also have this big challenge of chemsex. And also the Global Fund in Pakistan for last 10-15 years is only supporting the prevention of HIV among people who inject drugs. So we have more people who sniff, or smoke heroin. So my question would be that when we talk of harm reduction, what would you recommend other than a needle syringe exchange program for people who inject drugs for other drug users as key interventions going forward?
Very, very important question. I think, harm reduction is sort of an umbrella term for minimizing harm as a result of drug use. So obviously, the services that we provide to reduce that harm have to be tailored. In the case of chemsex and amphetamine-type substances in general, unfortunately, there's no sort of buprenorphine or methadone equivalent, but cognitive behavioral therapy and just general support and trying to intervene at an earlier stage are all important measures. The rise of synthetic drugs is also, like fentanyl and all that is very, very scary, if you like. And so provision of, I've been hearing a lot of overdose mentioned here. In Malaysia, for some reason, whether it's underreported, I'm sure there's quite a bit of underreporting, but it's not something that is something that we see very commonly, overdose, whether in the streets or in emergency department. But the provision of naloxone, I think, should be part of harm reduction services, where given that there's a lot of concerns around overdose. So I think what is important is to tailor to the types of drug use that's prevalent in your given community. And then, of course, you can call me the person who really wants to see drug policies change, because I think ultimately what is needed is regulation of drug use, whether it's cannabis, whether it's opioid or heroin, or whether it's ATS. I think the more we can regulate drug use, the more we can do things like drug testing, not in the form of urine, but particularly in more affluent countries where drug use is associated with, say, going to concerts and things like that. Some of the harm is related to the substances that's mixed in drugs, and so provision of drug testing has been shown to be effective in many situations. So there are many things that needs to be done. So there's no one size fits all, and also it's very complex, and there's no one answer. So again, kind of knowing, just like we used to say for HIV, knowing your epidemic, knowing your drug trends, knowing who's involved, and what the evidence for effective intervention is very important.
Thank you very much. Dr. Khalid, आप सवाल पूछना चाहते हैं, प्लीज।
I'm Dr. Ghosh, Coordination Manager, SIM from Nayi Zindagi. And Dr. Adiba, you have mentioned in your presentation that drug use issue should be taken as a public health policy, not another thing. But unfortunately, we don't have any drug advisory wing like Malaysia and other Southeast Asian countries. We don't have any drug advisory wing here, so we've not taken yet this issue as a health issue so far. And you have mentioned that the drug detention centers in your country were changed into voluntary services, but so far we have in our private sector and the public sector's centers who are providing drug treatment and rehabilitation centers not voluntary yet. So I'm just want to ask whether we should, if we awake and we move now towards that trend that provide basic rehabilitation services to drug users on voluntary basis, then we should move for making first step as the drug advisory committee, or directly we should move government to the for changing these private and public facilities in from detention type to the voluntary centers. What do you advise in our scenario?
Yeah, sure. Well, actually, in Malaysia, the move towards a more public health approach has been, I would say, gradual, and it's also through advocacy from civil society, from health groups, and only recently, after many years of this advocacy, so the changes in drug policy is very slow. The establishment of a national task force for decriminalization of drug use has only just happened like a month ago, a few weeks ago. So I think it takes a lot of advocacy, a lot of targeted advocacy from the health people. There's a lot of pushback from law enforcement. The transformation of the drug rehabilitation, the compulsory detention centers, to a more voluntary, evidence-based treatment, again happened with advocacy and happened because there was leadership within the National Drugs Agency that saw the need. But as soon as she retired, it reverted to compulsory detention centers, and we still have compulsory detention centers in Malaysia right now, unfortunately, because the laws were not changed. And so subsequent Director General said we have to follow what the law say, although it's, for me, I think it's misinterpretation of the law. But what you can do is, I think, speak to, we can connect you to the UNODC, and also UNAIDS at the moment have combined forces to advocate for to abolish these drug rehabilitation centers. And there are working groups that have come together under the umbrella of both UNODC and UNAIDS, at least in my region. I'm not sure which WHO region or which, it's quite complicated. Well, in the Southeast Asia region, UNODC and UNAIDS are helping us do further advocacy to abolish these compulsory detention centers. So that's one place you can go to.
Dr. Khalid ke baad aap. Thank you.
I shared that for IDUs you don't wait don't wait that they have to come to you. Instead, you have to go approach them, find their pockets, and give them the treatment or needle exchange, whatever desired. Do you think that it's feasible in Pakistan? My question is with Dr. Saima. Do you think that this idea is? To some extent, I'm agree with this idea, but I think this idea has issues and challenges as well. Definitely, it has. So, do you think that it's feasible or possible in Pakistani context?
Not fully feasible, but my own experience while we were implementing the HIV prevention model was that internationally it was recommended that you have community-led services for the communities in the communities. For the 5-year span now that this model has been implementing, we've seen that it has positive outcomes. It's difficult. The operational challenges are there. The constant brushes with the law enforcers are there. We have issues with the communities. We have issues with the service delivery providers. We have certain no-go areas where they cannot work. For injecting drug user, it has its own dynamics. You deal with a population that is barely normal to deal with, normal in the sense that they're not in a state of mind where they can better understand your communication. It's very difficult, it's very challenging, but I think at the end of the day, if we are actually to control the epidemic, this is the way to go.
In addition to this version, I would say it would have been started from Ladkana. As if I would have been the project director earlier, I would must suggest that start from Ladkana, because Ladkana town is in 2 or 3 kilometers in radius. So every drug injecting patient addicts can reach the center in walk. Otherwise, it is very difficult to start from Karachi, because Karachi is in 40 kilometer radius, and 40 kilometer radius, a drug addict can not reach on daily basis, number one. Number two, to reach these people, the challenge which I can assess and I can imagine, I can guess that if you are going to give them alternate medicine, those who are seller of the drugs, they will kill you. They will give you tough time. So it is very essential to be in a secure place to provide these medicines. However, this would be more feasible if outreach workers go to their places, bring them on the treatment center and give them these medicines.
Thank you.
It
Doc.
will be a public-private conversation. Like you're going to have the private sector working somewhere. You're going to have the government with the regulation, with the rules, with its overarching rule. So it's not something that you can give a free hand to one entity and not the other. So it has to be regulated through adequate policies, checks and measures. But it's a midway. So the government is going to extend an arm somewhere. The private sector is going to pick it up from somewhere. So it's either the service going and the person going, and there's a common point where they both meet.
Professor.
डॉक्टर उमर मैं बात कर सकती हूँ?
डॉक्टर खालिद अभी बोल रहे थे.
Habib Nala, my friend Amanullah will second me, City Nala. So all IDUs and other drug addicts, they are residing there, and they use that place for that purpose. And it's not possible for even police to go there and to do some to act upon those people. Sometimes the government uses FC and hire anti-narcotics force to engage those people, because beside these drug addicts, other criminal people, they are living there. So it's a very good topic, but there are a lot of challenges which are associated with it. So we have to see the challenges as well, because it's not it's not an easy task to do. It's my personal opinion.
So I understand what you're trying to say, because in KP also we have certain areas where you need permission of the army, you need permission of the rangers, you need permission of the MC. So you have certain no-go areas which are beyond access. So of course, like we were discussing, there has to be a midpoint. There will be a point where the government will come in, there will be a point where it's going to go into a semi-government sort of a setup, and then maybe a total private. So we need to find what works in that particular geography, the settings and the dynamics. Because like in KP, especially post-war on terror, there are too many checks. So we have Madam sitting over here, and they can fully understand now the dynamics of even just implementing normal service delivery in one of the major districts like Peshawar. So let alone the other areas.
Yeah.
So this is,
Dr.
I think, where we need to work on in our context.
Dr. Sharaf Shah, please. Iske baad.
I will lay on the question asked by Dr. Umar Riaz, and my question is for Professor Adiba. So before 2004 in Pakistan, there was no injecting drug use, and there was inhalation. and main drug which was abused was heroin. So started from 2004, and HIV prevalence in injecting drug users jumped from 0.04% to 4% in 2 years. But recently, we are observing reversal trend. Many patients who are injecting drugs now are shifting to inhalation. Due to the availability of drug, ice is used now frequently in biggest city of Pakistan, Karachi. So what is your opinion about that? That we have now shifting, and it's a public health point of view, that it's better. And it was worse when from shifting inhalation to injecting drug use. Now from injecting to inhalation drug use.
Yeah, the risk of transmission of HIV is still there. So in terms of minimizing harm for those who are injecting, obviously the classic needle syringe program, and if they're using heroin, it's buprenorphine or methadone. But for those who are now engaged in chemsex, the minimization, the harm minimization has to be different. So like I said earlier, we really need to be nimble and understand what the problems are. So in the case of chemsex that they've moved on to, PrEP is going to become very, very important, as well as all the things like cognitive behavioral therapy and so forth, which in the absence of people trained in this is also a challenge.
Thank you. Dr. Faisal?
I have a difficult question for Dr. Saima and Dr. Sikandar. And then Dr. Adiba, what she feels. The thing is, we talk about harm reduction, we were speaking about IDUs, but we're not addressing the big elephant in the room currently, which is poor IPC, which is we know how the infection spread in Arcana, we know how it's spreading now in the general population. And so my question is, what are we doing for IPC? Because nobody wants to own IPC. Everybody says this is not my job, this is somebody else's job. And then my question to Dr. Adiba is, how is IPC regulated or insured in Malaysia? So what are the mechanisms that ensures that hospitals are doing safe needles within hospitals, which is really where we're going to explode very soon if we don't do something about it.
So Dr. Saima and Dr. Sikandar, and then Professor Adiba.
Thank you, Doctor. You are our prime facilitator for this IPC subject in province of Sindh. He is associate professor in Aga Khan, and we respect Aga Khan and himself, because he was the leader when COVID came, and at the time of starting of COVID treatment, Chief Minister Sindh handed over his chair to him that address the people and give us the suggestions. So he should give us suggestion on this. But I would say WHO has done a lot during the period of COVID for IPC, but as such our attitude, our behavior is not so good. Even health workers have not good behavior in terms of IPC. We have repeatedly emphasized on this IPC to the health workers, at least segregation of the hazards and segregation of the things which are definitely very important to save the lives of the people, to save from the spread of the infection. But you are the leader in this in terms of IPC. So I would suggest you suggest all the people how to go ahead.
Thank you, Dr. Sikandar, and thank you, Dr. Faisal, for a very pointed question. This is the topic of our next brief that the coordinator has actually asked us to prepare in the context of HIV, that how do we plan to strengthen infection control measures across hospitals, across field settings, and what strategy should basically be adopted. It's not actually a very easy question to answer, but it requires maybe a long-term approach. We need to have some immediate measures, some mid-term measures, and then the long-term ultimate measure of infection control. Focusing on healthcare workers who are the prime handlers, taking necessary infection control measures while moving from patient to patient, disposal of the equipment, which is the vehicle of infection transmission, and then overall improving the quality of the hospital atmosphere so that the person who comes in for getting an infection treated doesn't take 2 infections home. The healthcare providers need to be focused. They need to be reinforced, taught again and again. We have the color baskets that I remember from my clinical practice, the yellow, the blue, and the green for the disposal of equipment. But how actually do we do it? We don't. I remember the house officers while rushing, isme dalne, usme dalne, acha chalo jo samne aaye usi mein dal do. That's the common confusion. In the rush hours when you're dealing in the emergency, you have too many patients, you barely have time to change gloves, you barely have time for maybe some basic measures. You've got the sheets contaminated. So I think IPC has to be made a regular part of our harm reduction. A low-hanging fruit for us could be our community health workers who are actually going on to the field. They're providing HIV testing services. We can guide them on basic infection control, basic disposal of that equipment, further handling. So we can bifurcate this from community to hospital settings. But like Dr. Sikandar said, I think we need to put a lot of our brains together to actually see an implementable IPC strategy.
Professor Adiba, how did Malaysia overcome this?
I guess this is taking me back a while, because I must say it's something that is already part of the culture. And as you were speaking, I was thinking, if I had to do this here in Pakistan, where would I start? It would probably be, a real culture change that it is unacceptable to have even one hospital-acquired transmission. It's going to be even harder in the community, but let's start with the hospital. I think it will need to come from leadership that it's completely unacceptable to have a hospital-acquired infection. And that would go with, in Malaysia we have hospital accreditation and things like that. I'm sure you have that too here. And so you're answerable to these hospital accreditation practices. And along with that, with leadership saying that this is unacceptable, you then have to put measures in place and invest in single-use needles, in those yellow bins. I'm proud to say that with the needle syringe program, even though it was run by the community, that the outreach workers in their backpacks carry not just clean needles and syringes, but mini yellow disposable bins, and having an SOP for needle stick injuries as such. So it has to start with leadership and calling out that this is unacceptable, and then along with that, putting in place all the measures that I've just said.
Thank you very much. Busha, you were waiting for a very long time.
I must thank all the panelists for their enlightening views about harm reduction strategies in Pakistan, especially Dr. Adiba for giving us more information on Malaysian model of harm reduction. And I'm also thankful to God that we have implemented harm reduction programs in Pakistan, which Zindagi is implementing. And I think many thanks go to Tariq Zafar also, his vision, his passion about his community, and his hard work that has paid a lot for the prevention of HIV in Pakistan. Now we understand that harm reduction has a lot to do with HIV and AIDS prevention efforts in Pakistan. So it is kind of equivalent to HIV prevention. But what I need, what I want what the panelists to please respond on is that is it only for PWIDs or the people who use drugs? What my little knowledge about harm reduction reminds me is that harm reduction actually started from work with female sex workers. This was first of all used with female sex workers in Netherlands. And the good exemplary work done with the female sex workers in Netherlands actually stemmed out of harm reduction initiatives, which was result of feminism and liberalism at that point. So keeping in view that many of the female sex workers in Pakistan are living in subhuman living conditions, keeping in view they are facing worst kind of sexual experiences, keeping in view the highest level of stigma one can ever experience, they are experiencing, and keeping in view that more than 85% of the female sex workers are currently using drugs, how can we make harm reduction strategies be possible, be available to those female sex workers also, and maybe maybe also to the transgenders and MSM who are living on the streets, who are using drugs, who are injecting drugs. Thank you.
Thank you.
Yeah, very, very important question. And I think a lot of us who work in harm reduction are also aware that many of the services are not gendered. And just like with everything else, if we put communities at the center, and like someone said at the beginning of the session this morning, if we make it a person-centered care, if we design programs with the input of female sex workers, we will then be able to tailor to their needs, whether it's clean needles and syringes, whether it's buprenorphine, methadone, PrEP, whether it's simple oral contraceptive pills that they need, or how to negotiate with their clients in terms of condom use. All these are not easy, especially if resources are limited. But I think if you work together with the female sex workers and get them to tell you what would work best, I find that these are the programs that usually are the most effective. And what I'm trying to say is I think it's not, you're right, it's not just about clean needles and syringes, it's a whole suite of things, and often in a very male-oriented harm reduction services, we forget all those other things that you're alluding to, like oral contraceptive pills and just simple empowerment and negotiation tactics for them to negotiate with their clients. Not to mention avoidance of intimate partner violence that we heard happen in big numbers during the COVID pandemic, for instance. So it's not an easy task, but I think if we have that gendered lens and a strong commitment to working with those affected as partners, inshallah we'll get there.
Thank you very much. I must say that this was the longest question answer session since the morning.
Dr. Umar, I have a question. Can I?
Okay.
Sorry, just
Yes,
last
please.
one. My question is for Dr. Adiba. In Malaysia, how do you deal with the communities when they are having multiple vulnerabilities, multiple risk behavior? For example, in Pakistan, we have Zindagi dealing with IDUs, and the rest of the CBOs dealing with MSM transgenders and the female sex workers. So is there any model where you are providing to those who are having multiple risk behavior, a one-stop shop kind of a service? If yes, how are you providing services in in-reaches and outreaches? Are there any integrated services? I would like to know from you. Thank you.
Perhaps Dr. Anita, did you want to answer this? As she showed this morning, we've kind of moved from a siloed approach to a more integrated approach between
Yeah.
NGOs and Ministry of Health and across different key populations, but
Yeah.
Anita will be best to
So
answer
because
this.
that's why I mentioned just now that we no longer assign one NGO just to focus only one key population. So we have already expanded, and we expand their role actually, so that there is no duplication. So one certain geographical area, you have one, for example, NGO, and that NGO, although basically or previously providing services only to one key population, for example, PWID, people who use drugs, but we give them, we build their capacity so that they also cover for MSM, transgender, female sex workers, so that you don't, so whenever they go out, reach out for key population, they can meet up with MSM, people who use drugs or transgender or female or women at risk. Anyone, any outreach worker can provide the service. So that is one. So, and this outreach from the community workers, they are doing outreach, they link all those key population back to us in the primary care, which is the integrated service from community-led service to clinical based. Right.
Thank you very much. Is there any other question?
Finished.
No. So as I was saying that this was the longest question answer session since the morning, and it was the last towards the end of the day. So IAS, please note how motivated and interested everybody is. So thank you again for the panelists.